This conference will now be recorded.
Yeah, nice. Yeah, we are 100 and counting. I think it is 10:30. We can start the session. Okay. Yeah, we have another session of pediatrics, right? Morning you had a talk by Madam actually. Yeah. Um Today our topic is about hemiplegia and chorea. Regarding hemiplegia, it is very useful for us in case of practical exams, and it is more of mostly, not mostly, it is all of practical importance. And regarding chorea, I don't think undergrad they're going to ask much, and they expect less. But yeah, but anyway, the topic goes. So yeah, we need to cover that also. So mostly the hemiplegia, we'll deal with the what is hemiplegia, which most of you must be knowing it already. Just look for some anatomy, physiology, and also yeah, the causes of it. Then maintenance, management, it is only the mostly the evaluation of hemiplegia is most important. And regarding chorea, yes, it is the movement disorder, and yeah, we'll deal with that movement disorder also. Okay. This may last for 40 minutes around. Okay, so kindly bear, and yeah, shall we? I think we'll start. Okay. Yeah, coming to the introduction, what is hemiplegia? Okay, as the name goes, hemi is half of anything. It comes from Latin or Greek, I don't know. And yeah, plegia is the weakness. Okay, paralysis or weakness of one side of the body, that is hemiplegia, and denotes involvement of pyramidal tract on the opposite side. Okay, because your motor system, as in physiology, we must be knowing the motor control of the body is crossed over. And that is formed by the pyramidal tract. Pyramid is because of the structure around the medulla. That is why it is pyramidal. Okay, we all know this, right? Yeah. Um, then it is not moving. Okay. Now coming to the pyramidal tract, which is the main motor control of the body. This tract starts from the cortex and then flows directly to the muscles and whatever the structures it goes by. And first of all, from cerebral cortex, it starts from Benz cells, layer 5, because there are 6 to 7 layers in the brain. And Benz 5 cells, layer 5 at the Benz cells, it starts and progresses into corona radiata and gets densely compacted in the internal capsule and then passes through the brainstem. Having said brainstem, it includes the midbrain, pons, medulla, and yeah, as we discussed, at the medulla, it is called the pyramid. It structures the pyramidal structure, and then 80% of the lateral corticospinal tract gets crossed, and 20% gets not crossed, and it is anterior anterior corticospinal tract. Okay, it becomes the anterior corticospinal tract, the uncrossed fibers, and then pass through our uh, spinal cord. Okay, this is how the tract goes. Actually, this is corticospinal tract, and also called as pyramidal tract. Yeah, this is the main thing, because why this is important is any abnormality at the location where the lesion is present, we can identify by the clinical presentation of it. And at its each anatomical site, there is a varied and specific clinical manifestation and physical findings. So this is important because whole of the tract from head to toe it is running through, and we should be knowing where the defect is there. Yes, your neuro imaging is definitely going to tell you, but clinically you should be knowing it anatomically, but you should diagnose where the defect is. Okay. Yeah, this is the pictorial depiction, and I think the labeling is smaller in size, but I think it shouldn't be a problem if you're watching. If it is in a mobile, it will be difficult, but in a system, I don't think it will really cause a problem actually. Yeah. From the cortex, Benz cells in the fifth layer gets into the these things, is the corona radiata, and gets into the internal capsule, very densely compacted. Whole of the hemisphere fibers gets compacted into the this boomerang shaped corona radiator, sorry, internal capsule, and then passes through the midbrain, pons, medulla, and where they form the pyramidal structure. This is the pyramidal structure, yeah, pyramid, and then passes. 80% gets crossed over to the other side, and only 20% gets stays. 20% that is staying is anterior corticospinal tract, and the lateral corticospinal tract gets crossed over to the other side. That is why any defect on one side, you can expect a lesion on the other side of the brain. Okay, this is how it depicts. Yeah. Okay. Yeah. As we discussed, yeah, the location is important because it the manifestation varies because based on the location. So coming to the first thing, the cortex, where the fiber starts and which is widely spread in surface area. Actually, the hemisphere is so much to cover. So there will be differential involvement. It based on what is the area that is involved, like whether the in homonymous the representation of the body, where it is involved, like whether the hands are involved or the legs are involved or any body part is single. It is differentially involvement can be seen. It is not the whole part of the body or half of the body getting involved. It is differentially. Oh, this small location of the body is involved because the rest of the fibers are normal, and because the lesion is at the cortex. Okay. And yes, when the cortex is involved, the gray matter is involved. When the gray matter is involved, the electrical discharges gets disrupted, and there is a high chance of getting seizures in this case. Okay, and when the cortex is involved, yes, cortical sensations are a lot. Your graphesthesia, your stereognosis, your two-point discrimination, all these are cortical sensory senses, and they get disrupted because your cortex is involved at that particular area. Mind that it is at that particular area, not a whole of the half of the body. Okay, and then coming to the speech affection, speech is affected mostly in the, whenever there is left hemispherical involvement, as the there's a famous myth goes by. It is not left to right handers and right to left handers. Most of the speech center both in right and left hander, it will be there in the left hemisphere. Okay, and once if the left hemisphere is gone, we can expect the speech is gone. Okay, yeah. This is how you can just see the patient, see the case. This is useful for your medicine. Yeah, it is mostly useful for your practical exams. Okay, to localize the lesion, they're definitely going to, whenever you get a case of hemiplegia, they're definitely going to ask you these things. Localization. What if it is what if the lesion is in the cortex? So you need to summarize these things. The sensations are cortical sensations are lost. Seizures are present. There is differential involvement. It is not whole of the body. It is only part of the body. And if the left side is affected, yes, speech is affected. Okay, this is how we need to tell. Yeah, coming down from the cortex, it is corona radiata, and once if there is involvement in the corona radiata, there is differential involvement as the same thing. No, not much, because as the cortex is not involved, the gray matter is not involved, the electrical discharges are not much involved, so there may not be any seizure activity that can be seen, or your loss of any cortical sensations like your graphesthesia and all these things may not be lost. Okay, but yes, there will be differential involvement, like the same thing, your limbs, or part of the limb or any other body surface body can be involved, because corona radiata is just like the radiations from the cortex, and which are getting converged into just imagine like it is a fan like thing, the fan, not the ceiling fan, it is the hand fan. Okay, just imagine it is in the arcuate like structure. The radiations just coming down and getting concentrated into the internal capsule. Okay, and the defect is at the middle. Okay, maybe the in fact maybe a bleed or any abscess tumor or something. Okay, and then coming down from corona radiata, it is the internal capsule. Internal capsule is a yeah, boomerang like structure, present bilaterally. Yeah, and yes, it contains the white fibers from the cortex into the internal capsule, and which passes down into the your brainstem. Okay, these internal capsule, whenever it is affected, and this is the most common site. Okay, just remember, you say this whenever seeing a hemiplegia, you say that internal capsule is affected. You're most of the times you are correct. Okay, whenever you are going to guess, you guess on this. Okay, internal capsule, yes, because yeah, here the things are getting a bit serious, because it is very dense, because all the fibers that are getting very much cramped up into just a few inches of white matter. That is your internal capsule. So even if a small dot in it, is going to represent very badly with the weakness of the body. Okay, still it is the opposite side. Okay, as we remember, it is still the opposite side. Only after the crossing of the midbrain, you're going to have your fibers cross into the other side. So it is still the opposite side. Okay, yeah, it is dense hemiplegia, because even if a small infarct or a small bleed, that can result in a lot of area that is going to be affected. That is dense hemiplegia. Use this word, dense hemiplegia. Your examiner will be very happy. Yeah, coming to the homonymous hemianopia, this is your visual manifestation because of the location over the your optic nerve and the chiasma. Okay, the homonymous hemianopia can be present, and hemisensory loss also can be seen because of its proximity towards the sensory nerves. Okay, that can be there, but you remember, use the term dense hemiplegia in case of internal capsule. Yeah, you will be out of it. Yeah, then again coming down a bit more, it is the brainstem. Yeah, brainstem, you will get crossed hemiplegia. Brainstem, having said brainstem, just imagine that we are talking about midbrain, pons, and medulla. All these constitute your brainstem. Okay, then the lesion, the manifestation will be crossed hemiplegia, as we discussed, and there will be cranial nerve involvement from brainstem, because brainstem contains the cranial nerves from 1 to 10. So the cranial nerves gets involved at this level actually. Okay, but the cranial nerves involvement will be on the same side. Okay, that is the important point in this. If the left is affected, and your left cranial nerves gets affected. Okay, but hemiplegia is still crossed, because only after the brainstem the fibers gets crossed. Okay, still it is the contralateral hemiplegia and the same side cranial nerve involvement. Yeah, coming to the midbrain. Uh, yeah, there are a few syndromes based on your scientists' names and all. Just this is for academic interest. Weber's is involvement of third cranial nerve, because midbrain, the higher place, higher nose. Okay, one is already, it is a connection from the nose, and two is your optic. So from three you get the nucleus most prominently. Okay, so Weber's third nerve and involvement of the pyramidal tract, and Benedict's is third nerve, involvement of pyramidal tract, as we discussed, and also the red nucleus. Just remember Benedict's, your Benedict's test, you get red brick or something. You just remember red nucleus is also involved in case of midbrain. Okay, coming to the next level, that is pons. The localization, you get a few more syndromes in lesions at pons. That is your Raymond, Miller-Gubler, and Fovili. And Raymond is your sixth nerve involvement. Yes, you're coming down, so your cranial nerves also gets increased. So yeah, it is your sixth nerve involvement along with pyramidal tract. Miller-Gubler is sixth and seventh nerve involvement. This is important. Just remember, because facial palsies and all, they do come, and it is Millet-Gubler is your sixth and seventh nerve involvement and pyramidal tract, and Fovili is your seventh nerve involvement and your pyramidal tract. Okay, and then down it is your medulla, where all the nucleus are going to stop, and after the medulla it is spinal cord. So the last few set of yeah, 10, 11, 12 cranial nerves gets nucleus from the medulla. Okay, the Jackson syndrome, it is involvement of 10th cranial nerve and 12th cranial nerve along with your pyramidal tract. Okay, just this is of academical interest. Just go through Benedict's, Raymond, Miller-Gubler is important. Okay, 7th and 6th. Okay, Jackson. Okay, yeah. After that, after the medulla, the cord goes into the cervical cord. Your spinal cord starts up, and the cord lesion above the level of C5, it is called as high cervical cord lesions, and where the face is usually spared, because your facial nerve, you happily crossed your facial nerve. Okay, facial nucleus and its parts at the midbrain. So there is no involvement of facial nerve, and then obviously no cranial nerve gets involved, because you're already through all these cranial nerve nucleus. Okay, coming to the classification, how do you say that it is hemiplegia? Actually, the topic is hemiplegia, but we are going to discuss more about the causes of hemiplegia. It is like the stroke, okay, acute cerebral accident. Okay, we are going to discuss. The head is different, but the concept is the same. Okay. Uh, Hemiplegia classification is, yes, in case of pediatrics. Now coming to the pediatrical, more into the pediatric detail, it is mostly congenital and acquired. Okay, the congenital is your cerebral palsy has one of the variant of the cerebral palsy is hemiplegic CP, so it can present at the time of birth, so it is congenital. Okay, and the other one is acquired, as the name suggests. The kid picks up while he's growing and gets manifested. Okay. Yeah. The pathophysiology is very simple, as we discussed. It is in the stroke we are discussing, because whatever hemiplegia is just a manifestation of something that is going inside. That is the stroke, say, cerebral vascular accident. Okay. So as we are discussing the manifestation, it means that we are also discussing the cause of it. See what happens, and why does somebody have a hemiplegia is because it's mostly the blood vessels. Okay, either there is an interruption of blood flow, whether there is an embolus or a obstruction or infarct to the blood flow to the brain, that will result in hemiplegia, or there is a rupture of blood vessel, there is hemorrhage, or your moya can present as a rupture of blood vessels and there is blood pooling out of it. Whatever be it, the part of the brain is not getting its blood supply. Okay, that is the end result of it. Okay, and then there is interruption of function. It's all the same. Or something tumor is impinging into your arterial supply, and there is AV malformations that is not properly getting distributed. The blood is not properly getting distributed into the brain. Okay, whatever be the thing, it is in and around your blood supply. Okay. Yeah, coming to the congenital hemiplegia, this is of some pediatrical importance. There can be vascular insult from birth or during the parturition. I mean, during the process of birth, or there can be infarct, and there can be cyst formation. There can arachnoidosis and fuses can be present. So cyst formation can be there, and MCA territory can be involved. This is middle cerebral artery, which is a branch of internal carotids. Yeah, they can be affected, and then the insult can be prenatal, maybe in the fetals or in the womb, or perinatal insult, as we discussed. Maybe this is during the parturition or after the delivery, immediately after the delivery. Okay, the preterms are mostly susceptible to get PVL, that is periventricular leukomalacia, which is asymmetrical and which will present as spastic diplegia in case of preterms. Okay, just remember, mostly it is vascular. Whether you is it an infarct, bleed, or cyst that is impinging into your arteries. Again, I'm repeating, and most of the it is MCA territory. Okay, as we discussed, it is the internal capsule. Where is the site of the lesion? You commit, if you don't know, you commit it to the internal capsule. And the what is the cause? MCA territory is the cause. You can just simply say this. Most of the time, it is correct in case of adults. Okay, not mostly in pediatrics. Yeah, mostly in pediatrics also, but in adults, you most of the time you'll be right. Okay, coming to the history, like how does the child or a patient or subject who is having hemiplegia present to you, or what are the things we need to actually look for? Okay, when we know the pathogenesis, we came to know the classification, we know the pathogenesis, and now how will the child or somebody is going to present to you, and who is going to express his symptomatology? Okay, it is history of paucity of movements on one side. The mother observes that the child is not using his right side or left side, his or her right or left side. That is how the mother comes. Previously the child used to move both limbs and yeah, very active, but now I observe that child is not using one side. Okay, and the history of early handedness, it is usually the 4th month, or the kids should start having the handedness and the preference. Whenever a toy or a bright object is given, the child has to reach for it with one hand. And if the child is reaching for it with only one hand at the early ages of 4 or 5 months, then that is early handedness. Okay, and the history of dragging one lower limb while crawling and creeping, yeah, obviously this is a sight to be seen. So that is how you know that one side is not uh, functioning properly. Okay, then history of not placing one heel or foot on the ground while standing. the same thing. Maybe the child finds it difficult to stand, move, and walk around. Okay, and the history of abnormal posturing because of the weakness of one side, there may be abnormal posturing or affected limb while walking. You get this all differentiation in normal gait. Normal gait will get disrupted. That is how the mother observes it. Okay, and presence. Okay. And a history of thinning of limbs because of long standing the caliber and functioning of the limb. And smallness of the hand, yes, because pediatrics, you are yourself, kid is not going to support you and say that I'm not going to function properly. Kids, you will be amazed to see they get looking, they're okay, they'll play, joy, jump, run, and everything they'll do with the right hand. They don't even mind it. So it is our responsibility to look after. An adult can notice it and come to you alarmingly with the anxiety, but kids, they don't do that. They'll be okay with any set of handicapness. Okay, they get adjusted very happily. Okay. So yeah, and seizures, as we discussed, if the cortical involvement is there, it is history of seizures and which can be focal. Okay. Yeah, coming to the general examination, what are the points you need to look for in a general examination? You have taken the history, and these are the things, yeah, we have asked in the history, which we need to be more yeah, pointed around. And now coming to the general examination, what are you going to see, look for? Okay, see, you are going to look for the posture. If there is any one side weakness, there is a tilting of the body or not using the limbs, that is how the posture gets differentiated. And contractures in long standing uh, weakness and disuse, there can be contractures of Achilles tendon, and there can be cortical thumb. Like cortical thumb is your ape thumb like thing. The thumb gets folded into the palm and it is not functioning because your thumb function is to oppose the all the fingers. Okay, that is how evolution has made humans superior to your closest relative of chimpanzees and monkeys. Okay, your opposition is the function of your thumb. Okay, that is how you are better than, yeah, sorry, not you, we are all better than monkeys and chimpanzees. Yeah, and if that is still there, it is a cortical thumb. Okay. Neurocutaneous markers, you need to look for the port vein stain. The one half of the uh, face has the port vein, that can be seen in Stretch Weber. You just look at the port vein stain and you can think that what is happening in the brain. There will be calcifications of the brain. Okay, that is a manifestation of Stretch Weber. And any facial asymmetry, to look for your facial nerve involvement, as we discussed, the lesion at the level of midbrain. Yeah, you will get your cranial nerves damaged. So you look for any facial involvement. And now coming to the CNS examination, as per se, the actual CNS involvement, higher functions usually they are normal because if the cortex is not involved, as we discussed, most of the time cortex is not the cause. So maybe it is corona radiate, or most of the time it's your internal capsule or beyond that. So higher functions are not usually affected. The higher functions are higher, that means your cortex is the reason for your higher functions. Okay, they're usually normal. And yeah, 33% will present with mental retardation, 25 with seizures. And yeah, cranial nerves, as we discussed, the homonymous hemianopia, when in case of your internal capsule is affected because of its proximity and the impingement of the uh, optic nerve at the chiasma, will result in homonymous hemianopia. Okay, yeah, I think you know about homonymous hemianopia. I'm just passing through because you are already done with your after in your third year. Okay, coming to the motor system examination. You look for any growth arrest and the bulk deficiency or something, we need to look for it. Okay, and compare nail size, because that will tell the small handedness, that is what it is. The thumb size, small handedness again, and hand size, because all these small things compared to the other side specifies that they are not being used over time. Okay, and measure length, that is shortening of the limb. And dystonia of the limbs, because your center is gone and you lose the muscular tone, so giving dystonia. Okay, and involuntary movements like yeah, chorea movements, that is what we are going to discuss later. Chorea is the dancing movements. Okay, choreography comes from chorea. Okay, dancing movements which are present while walking. Okay, if you have ever been to RR pet more, you can see there is one guy who is having chorea actually. Okay, one of the attending helper there, he's having, the guy who does the billing is having chorea. If at all somebody is interested, you can just go and observe him. Yeah. Yeah, spasticity. Yeah, spasticity is because of your, yeah, center is affected, the motor system gets affected and gets spasticity. Okay. And regarding the reflexes, yes, they're brisk because this is a human type of paralysis. Your center is gone, so yeah, brisk and exaggerated, and you can look for, you can get clonus also. This is important. Abnormal reflexes are retained, and sensory system involvement, it is the cortical sensation, as we discussed. It is 2-point localization, 2-point discrimination, stereognosis, and graphesthesia. All these are cortical senses. Only when the cortex is involved in your all the pathway, if only the cortex is involved, you can get this. If it is beyond the cortex, you are not going to get any of these. Is going to be well functioning. Okay, and hemisensory loss can be present down the pathway from internal capsule down the internal sensory system can be affected. And few things regarding the early signs of hemiplegic CP, that is, yeah, in pediatrics, you want to know, you're not going to wait for so long to find that yes, half of the brain is already lost. Okay, this is not the thing we need to see. This is not the thing we are looking for. So we need to pick up the cause early, because if there is a bleed or something that is happening, or there is an infarct, and you can save it in time, there are few signs that the child is actually going into hemiplegia. Okay, the first thing is, even after perinatally, you look for moros. Why you look for moros? If there is any asymmetrical moro, if not, the both hands are not coming through, only one hand is coming through and one hand is lying separately. So that is how, yeah, there is asymmetrical moro. And yeah, same in 9 months and above, you can see parachute. It can be asymmetrical parachute also. Yeah, the same mechanism, only one limb is protecting and the other one is not. Okay. And a early hand preference less than 12 months of age, yes, then you can think of maybe the other hand is not working, and maybe the cortical thumb, as we discussed, the thumb is not opposing, and you, the child is finding it very difficult to hold on to things and catch. Or you need to think that yes, there is a cortical thumb, and that is there should be a marker for us to look for hemiplegia and cause for weakness. Okay. And normal swinging of arm is lost during walking or running. The child keeps the hand close to the body and doesn't move it much. Okay. While the child is walking or running, so that is how we see that. Yeah, these are the signs how the present. It is most of the it as hemiplegia and comes to you. It is nothing, not much of the job as a pediatrician or as a doctor you are having. Okay, in case of pediatrics, even in adults, the patient is directly going to come and tell you that I'm unable to use my half of the body. So that is how you drop into your diagnosis of hemiplegia. Okay. Yeah, remember these things, because this is examiner's favorite questions. Asymmetrical moro, I'm repeating, asymmetrical moro, asymmetrical parachute, early hand preference before 1 year, cortical thumb, and loss of swing. Okay. Yeah, now you diagnosed and you have seen the case, you know the pathogenesis, that everything is done, and now you're going to investigate the child. Now, where is the lesion? You have examined and you have got an idea where the lesion is, and but you need to confirm it, where the lesion is and what has caused the lesion, whether there is an infarct, there is a bleed, or uh, yeah, any other impinging tumor or inflammation stuff. Okay. You go for neuroimaging, that is your CT or MRI brain. CT, you can get any bleed or hemorrhages, yes, you can get in CT, and it is faster, and any emergency situation you can do CT. But if you want to see the actual brain tissue getting involved or affected, you better go for MRI, which gives more detailed study of the brain tissue. You can see gliosis. Gliosis is involvement of the loss of the normal volume of the brain, that's gliosis. And prosencephalic cysts, the yeah, cysts can be seen. Schizencephaly, this is malformation, developmental malformation, hemiatrophy of the brain, and gyral calcification in case of Stretch Weber. Oh, Stretch and Weber are not supposed to be so separated. It should be in one word. Okay, Stretch Weber syndrome. Yeah, as we discussed, there will be gyral calcification in the brain. Yes, in CT also you can find it. Okay, and yes, you'll go for EEG because to see for any electrical abnormalities and hemispherical dysfunctions. Okay. And coming to the investigation for CNS infections, because infections can also cause CNS infections, and you do CSF analysis, culture the CSF and TB screening. The tuberculosis cause is always there, and PCR for herpes, viral infection. Herpes can result in these things, and viral studies, JE and other viral markers for LP from the lumbar puncture. You can collect the CSF and give it this. And coming to the investigation, even if when you think of ischemic stroke, you do echo, because maybe there is an abnormality of the heart, that is a large heart getting pulled up and giving a thrombus and a embolus into the circulation. Do the echo, and then hematological workup has to be done to see for procoagulation factors and procoagulation defects. Yeah, what you need to do is your protein C and S levels, antithrombin 3. We have a couple of cases here in our pediatric department. We diagnosed protein C deficiency, protein S deficiency, sorry, and antithrombin levels have been decreased in one case. Yeah, antiphospholipid antibody, that is very recent. During this lockdown, we found one antiphospholipid antibody also. Yeah, in case of adults, mostly endomeline, this homocystinuria levels cannot affected, and peripheral smear sickling can be there. Sickling itself can cause vasoocclusion and cause your hemiplegia. In serum lactate pyruvate levels can also be done in case of asphyxia and other uh, causes. And collagen vascular workup has to be done, like your rheumatology comes into play. You do your SLE stuff, that can give you idea. And now coming to the cause for hemiplegia, if it is your hemorrhagic stroke, how do you investigate? It's the same thing, right? Coagulatory profile and liver function test. Why why liver is it is because of all your coagulation factors gets formed in your liver. Yeah, this is a brief. Sorry, yeah, this is a brief assessment. Yeah, we will be concluding it soon. Yeah. This is a brief initial assessment of whenever a child with acute hemiplegia comes to you. History is always important. Anywhere history is important, and examination, as we discussed, what are to be asked in history and what are to be found out in history and what are to be examined in general examination and your as such CNS systemic examination. Then you go for investigations, like, yeah, as we roll down, what are the different causes, be it infection, be it an ischemic stroke, be it your hemorrhagic stroke. You've done and sickling, yes, sickling, don't forget sickling. Yeah, then you ask for a neuroimaging, because you need to know this idea. You imagine by with your exam, general examination, you have thought of the one location, and then you're going to see for the neuroimaging where the abnormality is. Okay, if the image is normal, we need to follow another protocol, and if the image is abnormal, we need to follow another one. Okay, just imagine. Yeah, this appears big, but it is simple. Just don't when you found a abnormal neuroimaging, there is some abnormality, then you should think of whether it is a hemorrhage or infarct. And infarct can be arterial infarct and venous infarct. I mean, it can be infection or inflammation, or there is any metabolic cause that is causing the defect. Or in case of a older child, you can think of press syndrome, that is posterior reversible leukoencephalopathic syndrome, press syndrome. Okay, these are the broad classification when there is an abnormal CT or MRI that you are going to look for. Okay, this is broad classification, that whether there is a bleed somewhere, you need to just go for vasculitis cause or any abnormality. When there is an infarct, it can be venous infarct or a arterial infarct. There may be infection, as we discussed. Infection is always there, and in India, TB is always there. So inflammatory causes and TB. And metabolic causes, you can think of melas and other mitochondrial abnormalities, mutations that can give down. And press syndrome, yes, in case of high blood pressure and AG and acute glomerular nephritis, yeah, you can see the child can manifest with the press syndrome and hemiplegia, and which is transient, and it can resolve after a few days. Okay, yeah, here of interest is arterial ischemic stroke. That is the most common cause. So you need to do ECG to look for any cardiac. then go for vascular imaging, and if the vascular imaging is normal, you can think of any vasculitis or SLE or such causes. And if the vascular imaging is abnormal, it can be moya or any arterial dissection or any arteriopathy, maybe hypoplastic arteries. Okay. Yeah, and then there is another situation where the MRI and CT is absolutely normal, and the child is having hemiplegia. This is another situation, and there you can expect a full recovery in few hours. Mostly your TAIs, that is transient ischemic attacks, can be there because of the spasm of the arteries they can present. And then you can maybe it is a seizure following giving rise to uh, paralysis, that is your thoughts paralysis, that is post-ictal. So you need to do an EEG, because your brain is normal, there is no lesion anywhere in the cortex, corona radiata, internal capsule, midbrain, pons, medulla. Okay. So we need to think of all these things, and they can be migraine can be presenting as epilepsy, sorry, yeah, it can present like epilepsy, hemiplegia, and there's different manifestations of migraine, not just headache. Okay, it has different. Yeah. And if you find some defect, you should always think of maybe spinal cord or rather other very rare causes of non-organic neurological syndromes you can think of. Okay, if the CT or MRI is normal, so most of the time it is abnormal, and this is what we are going to follow. Okay. Yeah. Now coming to the management, you investigated, you came to know that whether it is due to whatever the cause is. Now, as the logic goes by, it is you treat the cause. Okay, depends on the cause. Trauma, if it is there is trauma, you call for your neurosurgeon and ask for his help. And if there is tumor that is impinging into your arteries or vascular supply, get a neurosurgical correction. Abscess, yeah, you intervene appropriately. CNS infection, antibiotics, antitubercular, antiviral infections, you treat the infection. And vascular causes, which is mostly this is the cause. And if it is ischemic, your aspirin prophylaxis, because if it can happen now, it can happen again. So if it is ischemic, you just give for blood thinners, aspirins and stuff. And if it is embolic, there is embolus that is moving around, or if it is less than 12 hours, in case of adults, you can get a embolectomy done, and they can be normal. In cities, it is available in Vizag and Hyderabad, like that. You can get, if you're living here, you can transport them in that specified time. Yeah, embolus, you give anticoagulants to dissolve the embolus, and if it is hemorrhagic, you need to look for coagulatory abnormalities by the blood is oozing out of the normal vessel. And the other causes, your supportive causes, once the damage is done, is already done. So you do physiotherapy, orthotics, splints, all these things, and botulism, toxin in for spasticity and all those stuff. And yeah, almost always walk by about 2 years of age, because pediatrics, they have good neuroplasticity, and they can, yeah, improve over time, and almost they can do well in 2 years of time, 2 years of age, because they can overgrow. Okay. Yeah. And usually pediatric population, they can achieve independence of daily living, and not like in case of adults. Okay. Now this boils us down to the last topic, and this is a relatively smaller one, and I haven't put much of the slides because it is actually not so much for a undergrad. Okay. Yeah. Coming to the chorea, yeah, there is also a Latin word, chorea, dance. Definition, chorea, these two are two different definitions, but whatever. Okay, I'll just read on. Chorea is an unpatterned, which doesn't have a pattern. It can happen in any way, and which is involuntary. It is not under control. And hyperkinetic movement disorder. It is very fast moving. It is not a hypokinetic. It is a fast moving. Okay, this describes how the chorea movement is. It is continuous, variable in speed, unpredictable in timing and direction, and which is jerky in appearance. Okay, this is what chorea is. Just remember the words. Okay, you need to know. you need not replicate it. For a DM neurology, even for postgrad, I don't know all the words. Okay, this is how one definition goes, and the other one is this. I felt it comfortable, so I have put the next one also. Chorea is a movement disorder characterized by ongoing random appearing sequence of discrete involuntary movements. Okay, it is random appearing sequences of involuntary movements. This is I felt easy, so I have put it. Yeah, so why it happens, why chorea? Okay, uh, the pathogenesis of chorea classically results from dysfunction of the complex neuronal networks that interconnect the basal ganglion. The site is mostly important. Basal ganglion, thalamus, and related frontal lobes of cortical areas. Okay, when these structures, these complex neuronal networks are being dysfunctioning, then you want to do a movement and it goes into chorea. Okay, it doesn't go in a programmed and controlled manner, it goes out of control. Okay, that is how the pathophysiology of chorea is. The inputs of the basal ganglia from the cerebral cortex are glutaminergics and excitatory. Whatever happens in the basal ganglia, it is excitatory naturally. Okay, the majority of intrinsic basal ganglia circuit is GABA, that is inhibitory. From the cortex to the basal ganglia is okay. Whatever that is coming from excitatory, and whatever happens in the basal ganglion is inhibitory. Just remember this. Transmitters and dopamine. The output from basal ganglia to the thalamus and the brainstem targets is entirely GABAergic and inhibitory. Okay, whatever flows out of basal ganglia is inhibitory, whatever that is coming is excitatory. You just remember this, and whenever there is an abnormality in these functioning, you will get chorea or this purposeless movements. Okay, yeah, structural and functional lesions that involves that's decreased inhibitory output from the basal ganglion and cause chorea regardless of the specific focus of that abnormality. Lesions causing chorea are most likely to be located in the stratum, Niagara, and all the structures at the basal ganglion or the subthalamic nucleus. Okay, this is where the abnormality is there, and from the basal ganglion there is no inhibitory impulses that is passing, and only the excitatory. So that is how your chorea is coming. Okay, this is important, based on the known pathophysiology and the critical controls of GABA and dopamine. Your treatment is based on these things, because those are being inhibition is affected, so you want to inhibit it. So you're going to substitute your GABAergic and dopaminergic neurotransmissions. Okay, so your drugs follows. Okay, that is how your management stays. And cholinergic transmission is typically intact, the excitatory one. So anticholinergic medications are rarely effective in case of chorea. In sometimes of chorea, dysregulated neuronal discharges in basal ganglion circuits may be present, and this may explain the efficacy of anti-seizure medications in some cases. Okay, this is your when the cortex is involved and that is causing your chorea, your anti-epileptics may be helpful. Okay, no, this is just to run down. There are two things, that is acute chorea and chronic chorea. If it is lasting for few months, that is chronic chorea, and only for few days to for few days it is uh, acute chorea. Okay, the causes are autoimmune, infection, vascular, mitochondrial, metabolic, and toxin or iatrogenic or psychogenic. Okay, all these things produce the chorea. Autoimmune is your Swedenham's chorea, SLE, your antiphospholipid antibody syndrome, they can produce. Okay, and infections, yes, viral mostly, and mycoplasma, you always remember mycoplasma can cause this. And vascular, yes, as we discussed about stroke, arterial, venous, sorry, arterial, venous, and ischemic stroke, they can produce. Mitochondrial, yes, malas, your metabolic causes. And toxins, the carbon monoxide can give you chorea. And yeah, iatrogenic, your neuroleptics, antipsychotics, they can cause. And anticonvulsants are also can cause acute chorea. And once you disconnect, stop the drug, your manifestations also decreases. And psychogenic in conversion disorders. Conversion disorders is you can see the people walking, wandering in the roads. Okay, those are conversion disorders. They will have chorea movement. You can find a guy outside our hospital on conversion disorder. Yeah, yeah. Coming to the chronic cause, which are primarily it is chronic because it is hereditary, it is benign hereditary chorea. And secondary, again, your vascular runs, your strokes, and neurodegenerative sorry neurodegenerative causes like Leach-Nyhan syndrome, phenylketonuria, metabolic causes. They can cause this just to run down, okay, run down the causes. And chorea with ataxia, and they can be present in ataxia-telangiectasia. Coming to the management, you know that chorea is your visual diagnosis. You do your MRI neuroimaging to locate the lesion. We know that lesion is in the basal ganglion. So how do you treat? As we discussed, it is mostly your dopaminergic and GABAergic drugs, not the cholinergics. So your dopamine depleting agents like tetrabenzene and reserpine, and potent dopamine D2 receptor blockers like haloperidol and pymosine and chlorpromazine can be the cause. And atypical antipsychotics like risperidone can be cause. And anti-epileptic drugs like valproic acid, carbamazepine can be seen. Okay, and these are the few drugs which can be used in specific abnormalities, specific conditions. Okay, olanzapine, Sydenham's chorea, you can use olanzapine. Levetiracetam, it is an anti-epileptic and which can be used in dyskinetic CP and Sydenham's chorea. And topiramate, clonazepam, and gabapentin. And acetazolamide can be used in paroxysmal dyskinetic chorea. And methylphenidate, levodopa and levothyroxine in hypothyroidism. These can be used in benign hereditary choreas, and amantadine can be used in ataxia-telangiectasia. Okay, these are specific drugs that can be used in specific causes. Okay, just to run on the causes. Okay, yeah. Thank you. This concludes the class actually. Yeah. Any doubts? Hello. Hello.
No, sir.
No. Yeah, Pavan. Thank you. If there are no doubts, we can conclude the class. I know it is a bit, yeah, I think we did well, and you also 123 hold it well actually. Yeah, good. If no more questions, we can conclude the session. Shall we?
Yes, sir.
Yeah. Thank you. Thank you all. Thank you for your patient hearing. Yeah. Thank you.